on the way I speak, and some people find it very difficult because they're thinking, where does this go? And they feel a bit like this. And this is a comment from Yogi Berra. We don't know where we're going, but we're making good progress. Now, I know that some people hate that feeling of not knowing where they're going. So here's the outline of the talk. There are really 4 bits to it. The first bit is called On Being Hungry. The second is the pandemic and racialized groups. So that's where there's data. The third is a challenging question. How do you choose who dies? And the last tries to pull it together with the question, if diversity is our strength, and how come so many Black people are dying? And that really says what we should be doing about it. So let's start with the first, on being 100. So when I was in the UK, I used to listen in the morning to Radio 4. And Radio 4 had a morning show called Today, which was considered a must-listen show. And one of the reasons it was a must-listen show, it was highbrow news. All of the politicians would come up and talk on it. It was serious news. But they also had a lighter side. And one of the things they used to do was they used to interview people who had lived to 100, and they'd ask them about their lives. And one of the standard questions they always asked was, tell me your secret. Why do you think you lived to 100? And the usual reply was something like, I exercise every day, or I drink 4 cups of Earl Grey tea a day, or I have a wonderful family and a wonderful partner, or I have a superb job. But I remember one comment which made me laugh, and it introduces us to the first part of the talk. A 100-year-old woman was asked the question live on radio, what is your secret? Why have you lived to 100? And her reply to the interviewer was, well, dear, I think it was my decision to get off the Titanic. And she had been bought a ticket to go on the Titanic. She'd actually got on the boat at Southampton, got up to the bridge, and this was the first time away from home, and she got really homesick, and she got off before it sailed. And she lived to 100. And it's an interesting thing that she managed to get off the Titanic and live to 100. The RMS Titanic, this is a picture of the Titanic. Everybody knows about it, and nobody knows about it at the same time. It was operated by White Star Line and sank in the North Atlantic in the early morning of April 15th, 1912. The fact that it was the early morning was actually important. It had hit an iceberg. It was a maiden voyage from Southampton to New York. There were 2,224 passengers and crew on board. More than 1,500 died. That made the sinking of the Titanic one of the deadliest peacetime commercial maritime disasters. But whether you survived depended on who you were. 90% of children in first class and second class survived, but only 34% of children in third class. 97% of women in first class survived, but only 46% of women in third class. 33% of men in first class survived, but only 16% of men in third class. Now, the Titanic had a disaster strategy if it hit an iceberg, but it was a one-size-fits-all strategy. You had to wake up, and then you had to get to the lifeboats, and the people who got to the lifeboats were generally saved. But the people with the cheapest tickets were in the lower berths and the inside berths. And it was much more difficult for them to get to the life rafts. They needed more help, but the actual way that it was organised, they didn't get that help. So that the actual system was organised so that the people in the cheapest, with the cheapest tickets, those third-class tickets, were always less likely to survive a nighttime accident. In fact, the survival rates for the crew were higher than the survival rates for the people in third class. So this was something that was totally predictable. You could have predicted that this could happen. The likelihood of survival in case of emergency was actually designed into how the ship was organized, and it was acceptable. It was considered acceptable. And by now, you've realized that this is similar to our COVID response. We have a one-size-fits-all response to what is a natural disaster. We've ignored the diverse needs of the population. We knew that this one-size-fits-all would produce inequities in infection rates and deaths. But there is a difference. The difference between COVID-19 and the COVID-19 response and the Titanic is that we have a chance to redesign what we do for wave 2 and what we do for the recovery. We actually have a chance to get off the Titanic, and it's a choice that we can make. The pandemic and racialized groups. So this is part 2. So I work at the Wellesley, and the Wellesley is a classic think tank. If think tanks get too big, they get dysfunctional. So about 20 people is about a good size for a think tank, and that's where the Wellesley is at the moment. So in May this year, as we were reflecting on what was happening in COVID-19, and there are 4 Black members of staff and 16 members of staff who are not Black. Of the 16 members of staff who are not Black, some people had had family members who were tested, but nobody had been positive. Some people knew people who had COVID-19, but generally their families were intact. Of the 4 Black staff, 3 of them had had family members that had died. One had a family member, a grandmother in Mississauga who died. One had an aunt who was in New York who died. And my mother, who was in the UK, had died from COVID in London. So Black people in the UK, in the USA, and in Canada, all dying from COVID, and it seemed like a higher risk. And this experience of the Wellesley was actually very similar to the experience as the data started coming through from the US and the UK. The data from the US and the UK showed that you were 2 or 3 times more likely to get COVID and 2 or 3 times more likely to die if you're of African origin or you were of Caribbean heritage. And as that data started coming from America and the UK, 2 things happened. The first thing that happened was people started getting a bit uncomfortable here. And one of the reasons people started getting uncomfortable here is we didn't have the data. South of the border, our much maligned neighbours, who we are better than in every way, according to our narrative, and we have better healthcare and we have better social care, they have the data and we didn't have the data. And so that was one issue. And then there was a community push for data to start being collected on socio-demographics, who gets COVID and who doesn't get COVID, and also on race. And so that was one. That's what happened at that time. And the first analyses were geographic. And so this is just a normal Toronto Public Health sort of geographic map, and it's been updated. It's a map of Toronto, and the lighter areas have lower rates of COVID-19, and the darker areas have higher rates of COVID-19. And this is all cases, so this is cumulative cases in an area since the start of the pandemic. And what you'll see is areas, if you know Toronto well, that are highly racialized, the northwest of Toronto, some of the northeast of Toronto, and some parts of Mississauga. They're the places with the high rates of COVID. And those area rates are hugely different. And so we're talking about tenfold differences in one area compared to the other. So that's what the data started looking like and sounded alarm bells all over Toronto about what was going on. And then as the individual level data started coming through, we saw that the same thing was happening, and it wasn't just that it was areas, it was certain people within that area who were at high risk. Just going to take a... What this is these are rates of COVID per 100,000 on data that's been collected since May by Toronto Public Health. So 5,635 cases up until mid-September. And they started collecting socio-demographic data so they could see who was at risk. And you can see in the bottom right-hand corner, the white population have 79 cases per 100,000. So, but then if you look at the Latin American or the Arab and Middle Eastern, they're over 600 per 100,000 cases, 9 times higher, with the Black population at 547, so about 6 to 7 times higher. These are huge differences in risk between groups, and some of it is because of race, and also some of it is because of income. And so the same Toronto public health type data, same looking at rates per 100,000, and you can see that people with household incomes less than $30,000 a year, so living below the poverty line, have rates that are 223 per 100,000 compared to people who have household incomes of 150,000 or more that have rates of 42 per 100,000. So 5 times less likely to have COVID, to test positive for COVID if you're rich compared to if you are poor. But we need to be careful. Usually when we're thinking about the risk in a pandemic and the risk of health, we just look at the rates of illness and the rates of complications and the rates of death. But in COVID, that is only 1/4 of the story. So there are direct impacts of the disease, and those are clear. We measure those. But then there are impacts of the public health measures, such as isolation and physical distancing, which also have impacts on health. Then there are impacts because of the decreased availability of medical care. So if you have your an operation that is cancelled, or you can't get your normal follow-up appointment, or you can't get the medication that you have been relying on for years, or you are scared to go and see the doctor or go to the emergency department because you're worried about COVID, or it's linked to the impact of the economic downturn and you have lost your extended health benefits, so you cannot afford care. But the economic downturn also has led to increasing food insecurity, increasing unemployment and financial insecurity, increasing rates of risk of evictions, and a burgeoning tent city around Toronto and Toronto parks, all of which are more common for racialized populations than non-racialized populations. The UK government public inquiry, and I'll read this because it's a long slide, made it clear and how complex the rates for increased risk were, the reasons for increased risk were. Ethnicity and income inequality are independently associated with COVID-19 mortality. So income has its say, income is important, but ethnicity and race have a separate independent association, independent of income. Individuals from BAME, is called in the UK, which is Black and minority ethnic groups, are more likely to work in occupations with a higher risk of COVID-19 exposure. They are more likely to use public transportation to travel to their essential work. Historic racism and poorer experience of healthcare or at work may mean that individuals in Black and minority ethnic groups are less likely to seek care when needed, or, as NHS staff, are less likely to speak up when they have concerns about personal protective equipment or risk. And this sort of conclusion from the UK public inquiry does actually chime really well with what we found in Canada. We found that increased risks of use of the Kids Helpline for a Black population. We found increased risk of eviction and homelessness. We've actually found that increased risk of losing your job compared to other people during the pandemic, and increase in food insecurity in the Black population over that period of time. There we go. This is important for various reasons. One of the reasons it's important is because COVID is a social X-ray machine, and it highlights faults in our body politic and faults in our society. And one of the things that the COVID X-ray is telling us is that we have faults along racial lines. We knew we had faults along income lines, but Canada has faults along racial lines. So this next section, section 3, is challenging. It's challenging for a number of reasons. Everybody understands triage. A chap called Dr. Dominique Jean Larry, who's a surgeon actually during the Napoleonic Wars, developed the idea of triage. And it was supposed to be an equity tool. So the idea of triage was you were going to treat the wounded just on the observed gravity of the illness and the urgency of medical care. And it didn't matter about their rank or their nationality. And that's how the thought was in the Napoleonic Wars. And then it was taken into the French on the battlefield in World War I. And again, they were trying to be more equitable. They had 3 levels of triage. People who were likely to live regardless of what care they received. So those aren't people you prioritized. People who are unlikely to live regardless of what care they received. So they weren't prioritized. And people whose care may make a positive difference in outcome, where immediate care can make a positive difference in outcome. So what they were saying is that they wanted to save everybody who could be saved, everybody who needed care, and the triage is going to help them focus on making sure that people with the highest needs, people who had the highest needs, got the best care. So that was a basic focus. And it's baked into the way doctors think. It's baked into the way medicine's practiced, and it's baked into our pandemic strategy. It just took a wrong turn. Rather than being an equity tool, triage is now turning into a tool that could promote inequity. Now, I was asked to consult on the guidance that Ontario was going to give for prioritisation of COVID-19 beds if hospitals were full. So if hospitals were full, who should get an ICU bed? If hospitals were full, who should get an urgent care bed? And instead of just doing this triage thing of saying, okay, we're going to try and put as much care as we can as people who we can help, they started saying, well, no, we've got to consider inside that group of people we can help, who's most likely to survive. And so the focus then shifted to the effective and efficient use of resources. That's how it changed. And those people with existing chronic illnesses would be considered less likely to survive, and they would be have less priority. And the people most likely to survive, the fittest people, would end up prioritized for an ICU bed. So instead of it being an equity tool, it was starting to be an inequity tool, because the Black population were more likely to have chronic diseases. And so they, as a population level, be less likely to have access to care if it were being rationed. And one of the problems with this approach, apart from the fact that it bakes in an unfair situation, is it ignores social context. So the Canadian Medical Association did a study, I can't remember how many years, maybe a decade ago, trying to work out the contribution of different things to your risk of illness, and they called it what makes us sick. And they calculated from all the data they could that 50% of your risk of illness was linked to your life. So income, child development, education, social exclusion, your race, gender, whether you had safe and nutritious food and your housing, etc. 10% was linked to your environment, air quality, your civic infrastructure. And 25% was linked to your access to healthcare, how the healthcare system was organized, and the wait times in the healthcare system. But if you put those together, 85% of your risk of illness was linked to your social location. Only 15% was your biology. So when you find somebody with a number of chronic diseases, that's because of social factors. Their increased risk is because of social factors, not because of anything else. And if you put a one-size-fits-all pandemic strategy, you add that to an idea of efficiency and effectiveness, and you ignore these social determinants of health, you start producing discriminatory care. And it's unequitable discriminatory care. And it's one of the reasons why you can end up with significantly different rates of illness in Black populations compared to white. And then if you triage people's access to emergency care, why you'll end up with worse outcomes in one group compared to the other. Now, this isn't a new problem. This is a classic problem. This is a problem that health services have been trying to deal with forever. It's called the inverse care law. So people who know how to use the system, are most connected, and have the strongest voices get the most care. Problem is that they usually have the lowest levels of need. So in this diagram, levels of service on one axis, measure of need on the other axis, and you can see that people with the lowest need have the highest level of service. Now, this is how a lot of health systems work. This is how the health system in Ontario currently works, and this is how our pandemic strategy is currently working. The people with the most need are not getting the higher levels of service, they're getting lower levels of service. A health equity approach is supposed to do this. And the reason why you want to do this is because it's the most efficient and effective way of developing a health system and a pandemic strategy. This works, that doesn't. Aha, COVID knows this. So a lot of people say we're at war with COVID, and that's a weird thing because COVID, of course, is a part of nature, and being at war with nature is a very strange idea. But COVID itself doesn't want to kill us. It thinks that's a bad thing. What it wants to do is because it needs us to replicate and to grow and move on. That's what it wants to do. And it doesn't see us as individuals. COVID as an illness is an ecological idea that sees us as a society. And it needs to get into our society in order to replicate. So COVID has a really simple game plan. It finds the weakest links and it gets in. That's what it does. And then it spreads around. So it finds our weakest parts of society so it could get in. It targets our sick, it targets our old, it targets our marginalized, and that is COVID's game plan. Our main weakness to COVID as a nation is our vulnerabilities that we create socially. Our main vulnerability is inequity. And actually, our main tool for success against COVID should be equity. Here's an example. This looks like a complex slide, and it's not. It's a simple slide that tries to show pictorially and actually in numbers the number of people that a country would have saved if their pandemic response in the first wave had been as good as Germany. So if America in the first wave had a pandemic strategy that was as good as Germany's, they'd have saved 86,000 lives. Italy would have saved 28,000 lives. Spain, 23,000 lives. France, 22,000 lives. United Kingdom, 35,000 lives. And Canada would have saved 4,528 lives if we had as good a strategy as Germany. And some people say, well, what is the difference between what's happened in Germany and what's happened in Canada, and how could we have worked as well as Germany? Well, what Germany did early on is they decided that they had to have a strategy and guidelines and ways of enforcing good treatment in long-term care. That's all they did. They did all of the other things, tracing and testing, that everybody did. They didn't actually test or trace many more people than we did. What they had very early on at the time of their lockdown was they said, well, no, we're going to have really good guidelines for long-term care because we have to protect our most vulnerable. That was their decision. And that decision saved thousands of lives. The Statistics Canada and CIHI at the federal level did an analysis of lots of different countries, and they came to the same conclusion that a great pandemic strategy dealt with long-term care. And it's obvious why they had come to that conclusion, because 81% of people who died in the first wave in Canada died in long-term care. Ontario decided it had limited PPE, personal protective equipment. It decided to focus it on hospitals rather than long-term care. it decided that it was not going to be inspecting long-term care and face-to-face as it could have done. It eventually, when things went wrong, asked the feds to call in the army, but by then it was too late. If we had made different choices, we would have saved about 2,000 lives in Ontario. The thing that's difficult, and where I've come to with this question about how do we choose who dies, is that it's not clear who made those decisions and on what basis they made those decisions. So it's not clear who's responsible. And now I will be provocative. In police dramas, and I watch police dramas like everybody else, I watch police dramas, there's often a situation where X, Y, or Z person is missing, and people say, I'm sure they've been killed, and somebody says, we cannot say there's been a murder because, and we cannot prosecute because there's no body. So this is a classic trope within police dramas. And I put it to you that this is a case where we have literally thousands of bodies and apparently no crime. It's the other way around. It's not that we don't have a body, therefore we have no crime. We have loads of bodies, but apparently there was no crime. So where does this get us? How does this all pull together? So just to recap, Titanic had a one-size-fits-all escape strategy that led to inequities. Your gender, age, and social location changed your risk of death. Our pandemic strategy, very similar. One-size-fits-all strategy. Your age, income, race defines your risk of infection, of death, and of other social impacts. The way decisions were made on our pandemic strategy were not actually clearly based in social science, and they ignore modern ideas of how you develop fair and equitable pandemic responses, and that one-size-fits-all, inverse care law, triage-ish sort of strategy were all ingredients of a bad outcome. And that is one of the reasons why when we look at Ontario and when we look at Quebec, we have had a much worse pandemic outcome than they had in BC. In BC, actually, they had about 200 deaths in total. That's the same as in Northwest Montreal. So in Northwest Montreal, they actually had a few more deaths than in the whole of BC. But remember, the difference between our COVID response and the Titanic is we can get off. We can actually redesign our COVID response for wave 2, and we can think about how we build resilience in the recovery. If we'd made different decisions, we could have saved thousands of lives. And if we change our strategy now, we will save thousands of lives. Pandemic strategies are as strong as our weakest link, and our fracture lines are racial. COVID knows that. COVID sees that. And our best pandemic strategy is to decrease our social weakness and get rid of our fracture lines. We urgently need to change our pandemic strategy. There are loads of things you can do. At a policy level, move away from the one-size-fits-all and think about equity. Ensure that people with the greatest needs get most support. Change the law so that we don't hardwire inequities through poorly thought out triage strategies, and actually change the law and say, you know, in Canada, with everybody paying their taxes and with our diversity of population, actually setting up a clearly inequitable strategy just should not be legal. Why is that legal? Why is that okay? Clearly, we need to work with communities to work out why current guidance isn't working. They'd need better access to testing and tracing. We'd need to think about places where people can isolate. We'd need to think about protections for Black staff when they go to work. We'd need to think about the TTC. There are loads of things we could do, but fundamentally, we actually should have clear equity targets. We do not have an equity target in our pandemic strategy. We need transparent decisions so that we can see why resources are going one place and not another place. And we need to use tools like the health equity impact assessment for all of our decisions. There is so much we can do just on the pandemic strategy, but we may need to go further. And this is the last bit of the talk I'm starting to sum up. Mind the gap. If you, the wonderful thing about this gap between the train and the platform in the London Underground, and that big sort of booming voice that says, mind the gap, every time you're getting on the train, is the gap has actually been there since before Canada existed. That gap has been there for 160, 170 years. Since the start of the tube, the gap has been there. And the question is, why don't we fill in the gap? Because it would seem that it's time to fill in the gap. And in Canada, we used to fill in the gap in policy between the needs of the population to thrive and therefore we had a stronger society in loads of different ways. This is a classic 100-acre farm. The ideas and values were actually science-based. The government wanted to build Canada and wanted to give new immigrants the ingredients they needed for success. And actually, the deal was pretty clear. 100 acres made sense because an ox could plough 33 acres in one growing season. The next year, you'd leave that 33 acres fallow, so you needed another 33 acres. That gives you 66. Then you needed 33 acres of woodlot for your building materials and heating. And lastly, you needed 1 acre for your farmhouse. So 33 acres one year, 33 acres another year, 33 acres of woodlot, and 1 acre for your farmhouse, 100 acres. A strong Canada was to be built by the government, making sure that diverse newcomers had the opportunity to thrive. And everything has changed, and nothing has changed since those 100-acre farms came to be. The only thing is, we've still got population growth that's based on newcomers. We just don't support them well. So we don't support our Black population well. We don't give them a deal that allows them to thrive. And in fact, we've neglected the Black population so much that in Toronto, racialized populations haven't had a pay rise in 30 years. Living standards have dropped. Literacy is dropping. Poverty has increased. Food security has decreased. And the social safety net has decreased. Disparities in health are on the rise because disparities in health are due to the social determinants of health. What should be our strength, which is our diversity, is not a strength. And COVID has noticed. We actually do have the raw materials for COVID, for diversity to be our strength. We import smart people. In first generation Black immigrants are more likely to have a degree than the white population. But for it to be a strength, you have to do something. You have to, I mean, if it was a muscle, you'd have to exercise. Yeah, you might have the muscle, but you need to do the exercise. So, I mean, I guess you'd say if diversity is in to be our strength, Canada, we really have to work out more. This is a case of neglect. In my mind, it's a type of systemic racism. And the racism isn't simply the fact that this could have been predicted or the fact that we weren't collecting the data. It's the fact that we now have the information and we yet do not have a plan to deal with these disproportionate rates of infections and death in the Black population. We have no plan. And at this time, when our understanding of anti-Black racism has increased, after George Floyd, at the time where we really need to be acting rather than just talking, we really need to be developing a focused pandemic plan, an equitable pandemic plan, and then a focused recovery plan. It's because if we do nothing, then we're racists. If an organization sees huge remediable disparities in service or outcomes between racialized groups and does nothing, does not develop effective action, that is institutional racism. Seeing it and doing nothing is a form of racism. So we all want to live to 100. We can get off the Titanic because we can reimagine and reform our pandemic strategy and think of what we can do for resilience. This, in my mind, is something we can do, but this is also something we should do. And if we don't do it now, the question is, when will we do it? Thank you.
Wow. Okay. You've given us a lot to think about, and I see some questions are slowly coming in on the Q&A.
It's a university, so
right.
It's a university, so people get challenged.
Right. Of course, right. Yeah. Since it's a university, maybe one of the questions that comes immediately to mind is, what can we as individuals do? You know, those of us who are not sitting at the policy table, those of us who are not healthcare administrators or Ontario government, what can we do?
Well, I think that what a lot of people, I think policy, so if you are a hammer, everything is a nail. So my first view is, well, to tell you the truth, a lot of politicians are very sensitive to what people say. They are actually very sensitive to letters. They're very sensitive to talks like this. They're very sensitive to people saying for students or professors saying to their organization, what are you doing and where's your voice here? And U of T has a big voice. And so I think there is something there that people need to think about. There's a question in universities about where our research is and what our research is saying and what our research is doing, and whether we want to use the research leverage to produce information that indicates the issues. And so I think there's an advocacy, I think there's work. I think that the education about what's going on is very important, and we should all be educated to understand what's going on. And I think we need to ask for better governance and governance. The reason why so many people are thinking about doing things about Black Lives Matter is because people are sensitive to a public that starts expecting that that things change. And there's a joke that I tell people about why did the Canadian policy advisor cross the road? To get to the middle, right? And the thing is, in the past, that was okay in policy advice. People were looking on one side and the other side, balancing, trying to get as many votes as possible. It's not possible to sit in the middle on these issues. If you're sitting in the middle and you're saying nothing, you're considered to be part of the problem. And that's because we've had a cultural change. We've had a cultural change around Me Too. We've had a cultural change around Black Lives Matter, and you cannot be silent. And I think if we are vocal about the police, we need to be vocal about health and public health, because many more people are at risk and are not being saved by our pandemic response in the Black community than from the police response.
Thank you. One of the questions that has come in is, was SARS handled better?
Oh, it's, I wasn't here at the time. The thing about SARS, and obviously COVID is SARS, so this is SARS-2 as opposed to SARS-1, is that across the world, SARS was I think SARS was less infective, had many fewer problems, but if you do a comparative analysis compared to the rest of high-income countries, Canada didn't do particularly well in SARS, but doing not very well in SARS is 40 deaths, right? If you're not doing well in COVID, and say, for instance, we did as badly as they're doing in the UK, we would be, instead of looking at 10,000 deaths, we'd be looking at 40,000 deaths. So it's a different order of magnitude. I think the biggest problem we've had with SARS is not whether we handled it well or not. The question is whether we learned from it. And we seemed to be unprepared for COVID.
Or if anything, we might have actually been complacent.
Could have been, yeah.
I think. We were talking beforehand about a webinar I attended, and this was Carrie Ann, get her name, Douglas Powell from the Ontario Anti-Racism Directorate. And she used the term targeted universalism. That I think that what she meant by that was that if you fix the system in targeted ways, it would be of benefit universally. Does that apply here, do you think?
I think that the important thing is that we do have to have a pandemic strategy that speaks to everybody, because that is very important. The question is whether on top of that, we have a pandemic strategy that actually meets the needs of the most vulnerable. Because that is, in the end, that's our best protection. And so, yeah, I think you can think of the idea of targeted universalism, but to make it clear for the layperson, I just think that we need very clearly to say, if we think we have limited resources, and that is something that people say we have, then we have to work out how we can best use those resources. And we best use those resources by making sure that the people who need the most support get the most support. Unless we're going to, and I think people are getting it, because it's not like if we ignore racialized populations, they are not going to be in contact with anybody else, with non-racialized populations. We are all in this together. And a lot of the care that we receive is from lower income people. So we have to think it through.
Right. So a lot of the comments that are coming in are really more comments than questions.
Are they comments that go up at the end, and that makes them questions?
Well, they're comments basically sort of thanking you for raising important issues. Someone condolences on your mother. This one I think is maybe a question or a comment or follow-up comment. That the person who asked about SARS became interested in these issues as a result of the Toronto Social Planning Council's access to health and social services that was presented in the 1970s. I wasn't here then either, so I'm not sure about that.
Well, I was alive, but I was in the UK. So I wasn't here. So, and the only wonderful thing I think about my journeys in Canada, and I've been here 13, 14 years, is just about every time I think I've had a new idea, somebody somewhere has done it before. And we seem to reinvent the wheel rather than build. So it wouldn't surprise me if somebody hasn't thought about this before and maybe done it and it's died and we don't know why.
Right. Does anybody have questions that are more of the question that could be answered or addressed? Or I can keep babbling. One of the things that really struck me as a transplanted American when I got here is the lack of race-specific data. That was just stunning to me. And I understand, was it 2018 that there was finally a racial data standards implemented in Ontario? Something like that.
Yeah, there's been people haven't wanted to talk race and people haven't wanted,
Right.
you know, there's been a lot of work that needs to be done. Not surprisingly, people worried that race data will be weaponized against communities. And so I think now when we're thinking about race data, we have to be very clear what the data is going to be used for, and we have to have governance that allows community governance over the data, so it's used for the purpose it said it's going to be, and it's used properly. And so I think there have been some sensibilities around data collection, but I also think there have been people who just haven't wanted to know. And the thing is, in a democracy, if you're not counted, you do not count. And the aggregate doesn't tell the story of the individual, and it doesn't tell the story of racialized groups. And so your voice and your story gets completely lost. So you have to balance this idea of needing the data in order to make change, and being careful on the use of the data. If there's no data, there is no change. No one does anything.
Right. I'm seeing questions coming in both in the Q&A and in the chat. Okay, I can manage two things at once. So here's a question. How do you think the virus will continue to impact our lives, and what can we do as citizens other than wearing a mask to keep each other safe?
Well, I think that I was really taken by the fact that we are learning as we go along. Yeah. So one of the things that we know is that the testing and tracing and various other things work. Some people say, we haven't got maybe we haven't had a good pandemic strategy. Well, I can tell you, if you're in the Atlantic provinces, if you're in BC, you've actually had a very good pandemic strategy. And in places like Toronto, the pandemic strategy for the white population has actually worked pretty well. It's for racialized folk that we haven't tailored the strategy, so it hasn't worked. I believe that the natural history of these sorts of viruses is that they work out that killing people isn't very effective, and they often mutate to be less fatal. So there's that happens over time. But that's over a number of cycles. I believe that there will be a vaccine eventually, but I do think we need to be thinking about innovative ways of doing things. And to a certain extent, we need to be trying to work out whether we can produce a new normal that was better than the old. Right. Because it may be that we have to find ways of developing community and living full lives with COVID in the background for a little while yet. And so, I think in the back of my mind, I've already started thinking, it's not a matter of going backwards, it's a matter of going forwards. The Maori have this idea that we walk backwards into the future. Ooh. And the idea is that we're so concerned and so focused on what's happened in the past that we're looking in the past while we're stumbling over predictable issues in the future. And the question is whether we can turn ourselves by 90 degrees so that we can see the past and be informed by the past, but we can actually see the future and the possibilities in the future. Right. And that's where I go. I say, what can we do that's positive?
Okay, so I'm going to combine here a couple of comments and questions. There's one sort of comment, I guess, talking about the TTC strategy with buses that are too full in some of those very densely populated areas, that instead of adding more buses, they're simply saying people should get off and get on the next one.
Unfair.
Yes, absolutely.
And
then, yeah, go ahead.
No, I'm saying that unless you link it all together and there are no penalties on people's work, for people coming to work late, and you change their hours to become more flexible, and you allow them to get home on time, otherwise it's just unfair, and it will lead to stresses and more COVID and more mental health problems.
Right.
It's unreasonable and unfair.
Right, because most of the people who are taking buses because they have to get to work and they don't have a choice to work at home the way many of the rest of us are doing. Yeah. So the question that I think connects to that, someone's asking, what specifically would you be recommending to ameliorate health outcomes for Black people? Nice specific question. More generous income supports, better access to housing. It seems very broad to try to reform our entire social safety net. Any specific Black focused recommendations in addressing the weakest link?
Yeah, well, I like the question because people are saying, okay, well, we need to do something specific for the Black population. Why would we want to reform everything? I tend to say, well, if you've got a system that isn't working for half your population, so when you look at racialized folk in Toronto, that's half the population. And if that population, as in is 82 or 83% of COVID, the people who've got COVID, then your reform is, and if that population is much more likely to need social assistance, then the reason why you need to reform social assistance is because it doesn't work for the very people it's supposed to help. Mm-hmm. And so it is organized for the minority of people rather than the majority of people. So it does actually need a recalculation and a reformation because it's not working for the very people it's supposed to support. Mm-hmm. So I think there is that issue, but I do think that actually having the discussion with communities about what works, what doesn't work, and things like that makes a big difference. Here's an example. Very early on in the pandemic, the CERB came out, and the CERB came out as $2,000, and it was $2,000, and you either had lost enough income that you got $2,000, or you got nothing. Yeah, we heard from communities that was unfair, that people were working 2 jobs and they'd lost 1, right? So then they didn't get any CERB. We went back to the federal government and we said, hey, have you heard this? And they said, well, we've heard it from you and we've heard it from other people. The CERB was reformed within 2 weeks. Wow. Right? And it just didn't work for low-income populations with 2 to 3 jobs. Just didn't work. And they reformed the whole thing. Mm-hmm. And I do think that this is a time, in my mind, to start thinking big. It wasn't working before. And I've got no problem with the idea of thinking about significant restructuring of our safety net to meet the needs of the population.
Right. Actually, that's a great example of people think, well, it takes so long to move government or to make any social reform, and that one happened so fast.
Well, that's one of the things about the pandemic. There are things that we've never been able to do in health that were done in a day.
That too.
Right. Not always well, but they were done. Right. And if that energy can continue, then the future looks a bit different for us.
Mm-hmm. What would a basic income program do?
So now, you know that this is a past trauma of mine, don't you? So I was the research and evaluation lead, the sort of board lead for the basic income pilot. So I was there from the setting up through to when it was cancelled. And we saw a significant change in dignity. We saw people going back to work. We saw people alleviating their stress. We saw people making entrepreneurial decisions. And all of this was based on freedom. The freedom that they were trusted by government to make positive choices in how they were going to live their lives for Canada by being told that there was a flaw. So back to a boating analogy, but not to the Titanic. About 65% of people in Toronto are on a luxury liner. They've got the greatest life there is. Toronto's a great place to live. 35% of people are in the water. Some of them are already drowning. Others are treading water. The problem with treading water is if you stop, you drown. Right. If you continue, then over time, because of the energy you expend, you die younger. Oh. Okay? So all that the idea of a basic income is saying, well, actually, we're going to put a platform under people. We're going to make sure they don't drown. And my view is that that is a completely reasonable thing to do in a society. At the moment, our social assistance rates are so low that 40% of people on social assistance are living in poverty. And we know that people who live in poverty do not live as long as other people. Right. So the basic income as an idea, whether it's called the basic income, whether it's called guaranteed income, whether it's a whole bunch of things put together to make a floor for people, I think is the mark of a caring and reasonable society.
Okay. Sort of one last question I think we have time for, and I'm trying to combine some things in ways that maybe don't work. So there was a bunch of questions that were more like comments about talking about race. You know, if you focus on Black population, is that discriminating against other ethnic groups? And other people were saying that non-racialized Canadians don't want to talk about race, as if ignoring race means that racism doesn't exist. I think, you know, there's some fairly big answers to that, but could you comment on that one?
Yeah, I think that they're completely right. The idea and the data, because we've only got half an hour, I had to focus on something. I focused on the Black population. And you know, I could have focused on the South Asian population. I could have focused on the Arab and Middle Eastern population. And many of the things that are said would be very similar. I chose the Black, and I could have talked about the Indigenous population, but I'm not of Indigenous origin, and I'm not an Indigenous scholar. So I think the important thing is to not just say, okay, well, focus on the Black population, just do the Black population. I think you could argue from the statistics in general, not just in COVID, that the Black population and Indigenous population are highest needs populations. But the idea of equity is that your response depends on need. So if you've got high need populations, you do the high need populations, but that doesn't mean you don't do work for the population of just less needs or just less needs or just less needs. So this is a rhetorical device. Yeah. Equity is for everybody. You do have to focus on the highest needs, but you know, you build the idea of that equity map is that your response base is based on the needs of different populations.
Right. Thank you. Well, that seems like a very good sort of hopeful place to end. And normally at this point of the event, I would be inviting everybody to stay for a reception, but as we know, that can't happen these days. So instead, I guess I will invite everybody to join me in silently thanking Dr. McKenzie for a very thought-provoking talk. Thank you.
Thank you very much.